Hey guys, so remember all the talk in OB about impending signs of labor? Decided I'm going to go ahead and put this cardiac lecture up just in case that takes place. So we're going to discuss Chapter 37, Pediatric Cardiovascular Hematologic Disorders. So the first part, and it begins in your book 812, Chapter 37. First part of it's talking about growth and development of the cardiovascular and the hematological systems. When this is affected in a child, it's usually going to be pretty serious. It can be chronic or it can have long-term conditions. And you have to go back to chapters 21. Think about some of those congenital issues we talked about. Think about even like fetal development, the normal fetal development, how they have that peak to ductus arteriosus, PDA. If that doesn't close off, it can cause a murmur and it can cause problems. And there can be problems just where the septum of the heart, the in-between part, I know I'm making a false heart here, but that part, that muscle that goes in between the ventricles and the atria, the septums, there can be holes in those areas, or there can be great vessels where they're going to the wrong place. So any of these problems can cause huge, significant problems in the children as well. Think back to the differences between the child's system and the adult system, the infant system, even the unborn infant system, and how many progressions they have to, how many transitions they have to make in order to be able to transition into a normal breathing and normal pattern of life, normal hematological pattern. The congenital diseases, they refer to that defect in the heart or the great vessels, persistence of a fetal structure after birth. Deaths from heart defects have declined dramatically over the past 50 years, and now approximately about 85% of newborns with congenital heart diseases are expected to survive to adulthood. A lot of times we can pick them up on ultrasound. We already know that they have a problem. We'll send them out to a larger hospital where they can actually do the surgery that day on a newborn infant. It's pretty miraculous, actually. Most of these congenital heart defects develop during the first 8 weeks gestation. They're usually a result of genetic and environmental factors. Okay, so the first disease process we're going to talk about is congestive heart failure. And so with congestive heart failure, it's basically just a disorder of circulation in which that cardiac output is inadequate to support the body's circular system and metabolic needs. It occurs when blood and fluids accumulate in those organs and those body tissues, and the heart just isn't able to pump. It gets tired. You can see my picture of my exhausted heart. Blood and fluid accumulate. The heart's not able to pump and circulate enough blood to supply the oxygen and nutrient needs of the body's cells. So when the cardiac output remains insufficient, the body's organs and tissues don't receive adequate oxygenation. Congestive heart failure develops slowly, and symptoms might not be recognized at first. There are different symptoms for infants versus the child, and that's just part of growth and development that you need. Growth and development is going to be around all semester long. Throughout the entire course of Pedi, we're going to be talking about it. So make sure you're kind of thinking about that in the back of your mind. What's going to be different for an infant versus a child? So with an infant, the infant is going to tire very easily. They're going to try and take a bottle of milk, or they might even try breastfeeding, but they're just going to get frustrated during the feeding. They'll eat for just a small amount of time, and then they'll be exhausted. They'll have rapid weight gain or rapid weight loss. Think about the fluid accumulation or the weight loss because they're just not able to gain any weight due to this process. Diaphoresis, irritability, restlessness, and frequent infections. And typically what you'll see is they'll start taking a feed. They won't be able to tolerate it. They'll stop, but then they'll be super fussy an hour later because they're starving. They're so hungry. As the disease As disease progresses, tachypnea, tachycardia, pallor, cyanosis, molted, pale, nasal flaring, grunting, retractions, coughing, crackles. They're not getting the oxygen they need. Paraorbital facial edema, hepatomegaly are signs of fluid overload. Remember the liver enlarges. And then we can even go into cardiomegalia, which will occur as the heart keeps attempting to maintain that cardiac output, but it's just not. The heart is a muscle, so it's going to get bigger, but it's still just not able to get the cardiac output to the rest of the body it needs to. Medications and treatments. So here are some of the things that we are going to do for this patient. We're going to raise the head of the bed because they're going to tire out easily. They're going to be short of breath. So we want to raise that head of the bed. We want to put them on bed rest, look at their energy requirements, and try and make them where they do the least amount as possible. We're going to give them small frequent feedings because they are going to tire out so easily. We want to keep those feedings to a minimum. For our medications, digoxin, lenoxin, it slows and strengthens that heart. With congestive heart failure, there is a lack of cardiac output, and therefore the heart rate is going to speed up. You're going to be tachycardia because it's going to try and overcompensate, but it's not going to work. We have to slow that heart down, get a good contraction, and that's what digoxin does. We want to give them oxygen because they are short of that breath. We want to give them Lasix to remove some of that fluid. Remember, it's a buildup of that excess fluid. So we'll pull that fluid off. Allodyactone, spirolactin, also an diuretic, potassium sparing, remember. We've got ACE inhibitors given to vasodilate, to open up those vessels. And remember, those are your opriols. Rheumatic fever. So rheumatic fever is acquired heart disease. Rheumatic fever, it's going to be that systematic inflammatory disease that involves the heart and the joints. Central nervous system, connective tissue involvement may also occur, and it's that autoimmune reaction to group A streptococcal infection. So hopefully you remember that from med-surg. It can occur 2 to 6 weeks after an untreated or even a partially treated streptococcal infection like strep throat, tonsillitis, scarlet fever, or pharyngitis. So we always want to teach our parents, make sure that they are giving the antibiotics, the full dose of antibiotics. Don't just stop after the child gets to feeling better. With rheumatic fever, you have that picture of that child on 816 where they're showing the different signs. It starts out with minor fever. They're going to have that elevated CRP and that ESR, which shows us that they're having an infection of some sort. With rheumatic fever, we do actually base our diagnosis on Jones criteria, and so this is two major and one major and two minor criteria. And so the major criteria are obviously going to be more of those areas deeply affected and the ones that can cause more problems. So polyarthritis, multiple joints are inflamed, and of course it's going to be mostly your large joints, your elbows, your knees, shoulders, things like that. Carditis, you'll hear a murmur, you'll hear a pericardial friction rub, remember that sound of leather. Changes on the EKG, tachycardia. Chorea, remember, have that picture of that in central nervous system. It's just a uncontrolled shaking involving involuntary movements of the limbs. Emotional liability, slurred speech can even occur. Erythema marginatum is an erythema, basically it's a mascular rash. It's something that usually you're going to see on the trunks and the proximal limbs. And so, very bright red rash. And then subcutaneous nodules. These are big, painful nodules, non-tender nodules. These aren't the painful ones. These are the non-tender nodules that develop on the skin. So then you have your minor criteria, your arthralgia, your fever, spiking temperature, your elevated ESR, your CRP. You'll also have decreased red blood cell counts. You'll have a prolonged PR wave or QT interval on the EKG. And all of this is kind of supporting evidence. It kind of shows that's what we're leaning towards. Rheumatic fever is kind of difficult to diagnose, and sometimes it's impossible to differentiate from other diseases. usually what we're going to look at is that history of streptococcal infection, history of scarlet fever, positive throat cultures for streptococcus, elevated anti-streptonin or positive ASO titer. All right, so in your book, you're going to have your assessments. You're going to have, where is it? You're going to have your nursing process on page 818 to 819. Definitely read over that. You know, that's always a great place to grab some questions from. When you're doing a review of systems, you're asking questions related to reports of sore throat, activity level, chest pain, fatigue, joint pains, rash, kind of trying to get a good history on that. Physical exam, you'll do vital signs, oxygen saturation, observing for hypotension, fever, hypoxia, assessing for symptoms of any kind of carditis. Remember, that's inflammation of that heart. So they'll have low-grade fever, pallor, listlessness, poor appetite, dyspnea and exertion, auscultate the heart, no tachycardia, any kind of new murmurs or muffled heart sounds. And we'll do an EKG on it as well. We'll be assessing the joints for painful swelling symptoms last a few days, and then they'll disappear without treatment. And then they'll return to another joint. Okay. Rheumatic fever, we're palpating the skin near the joints for non-tender subcutaneous nodules, assessing the skin for erythema marginum or pink macular rash on the trunk and the abdomen, non-itchy and disappears rapidly, assess for signs of chorea, bed rest until those ESR levels return down to normal, so we know that the infection has come down. Tachycardia and the fever have subsided. Design nursing activities to promote that rest and encourage diversional activities which do not stress the heart. They will get bored, so we have to make sure we're taking care of that. Bed rest with bathroom privileges. We kind of already, we didn't talk about medications. So medications, antibiotics, they need to be on penicillin, and of course we want to make sure that we are eliminating that streptococcal infection. We will use erythromycin if they're allergic to penicillin. With this, we're going to administer aspirin. It's got that anti-inflammatory agent, and so aspirin will relieve that pain dramatically just after a few doses. Remember, real painful joints, so we're using aspirin to take care of that. And of course, everyone's kind of radar goes off with aspirin. It does put you at risk for Rye syndrome, but that's usually whenever they're giving it with a viral infection, so we do have to kind of watch that. But in this situation, in this case, we are also weighing the benefits versus the ill effects. Okay, so with teaching, you're going to make sure they finish the antibiotic therapy, do it completely, promote rest, nutrition. Prophylactic antibiotic therapy will be needed, obtaining antibiotics before any kind of dental work, and all invasive procedures because they are at risk to go back to this. Medical follow-up care for at least 5 years, usually until the child is 18. Okay, and here's a question for you. So a nurse is teaching the parents of a child diagnosed with rheumatic fever about the prescribed drug therapy. Which statement would indicate to the nurse that additional teaching is needed? A, to prevent another episode, she'll need preventative antibiotic therapy for at least 5 years. B, she needs to take the drug for the full 14 days. C, if she needs dental surgery, we might need additional medication. And D, we can stop the penicillin when her symptoms disappear. So which one's going to indicate that the nurse needs additional teaching or needs to do additional teaching? Obviously it's D. And explaining that the child with rheumatic fever has to complete that full antibiotic therapy, 10 to 14 days, ensure complete eradication of the infection. Drug can't be stopped when the signs and symptoms disappear. And to prevent recurring attacks, prophylactic antibiotic therapy is prescribed for at least 5 years or until the child is 18 years. So yes, we didn't quite touch that one, but antibiotic therapy goes on for this child for a long, long time. So, Kawasaki's disease. Kawasaki's disease is acute systematic inflammatory illness. It occurs primarily in toddlers. In the U.S., its most common cause of acquired heart disease in children may be preceded by an upper respiratory infection. With this, you are going to see an alteration in the immune status. Typically, what you'll see is kind of three different stages. The acute stage, you're going to see fever that's greater than 102 for 5 days, conjunctivitis, red throat, strawberry-colored tongue, dry, cracked lips, just peeling. Their hands and feet, they'll just peel off in layers. A rash on the trunk, enlarged cervical lymph nodes. Remember, altered immune status, so yes, really large lymph nodes. Inflammation of the arteries, the veins, the capillaries, all can occur, and this can lead to serious cardiac concerns. Aneurysms, thrombosis, so gotta be careful there. High fever doesn't respond to antibiotics or antipyretics. And in the acute stage, or that fever doesn't respond to antibiotics or antipyretics in the acute stage. Subacute stage, bring it down. Fever will resolve. It's still irritable. High risk for aneurysms, cracking lips. Again, the skin on the tips of the fingers and toes will just kind of peel off. Joint pain, cardiac disease, thrombocytosis. And then you have your third stage, convalescent stage. Symptoms are gone, appears normal, but lingering signs of inflammation may be present. And this phase continues until all the lab values return back to normal. The cause of it is unknown, but causes may be infectious in genetically predisposed children. It's not spread person to person. There are diagnostic tests that we do, and of course that's going to be, it will show those inflammations, that high level of inflammation. So we'll have an elevated erythrocyte sediment rate, elevated white blood cells, mild anemia, elevated platelet count during that subacute phase, elevated C-reactive protein, that CRP. And then the EKG will actually show some vascular changes in those heart and coronary arteries. Remember, it's an inflammation of the arteries, veins, and capillaries. Puts them at risk for thrombus and aneurysms. With the Kawasaki's disease, medical management is intravenous immunoglobulin, IVIG, and high doses of aspirin, 80 to 100 milligrams per kilogram per day in 4 divided doses while the fever is high. Immunoglobulin early has shown to reduce the incidence of coronary artery lesions and aneurysms. With Kawasaki's disease, it can lead to those cardiac problems and can cause bad changes to it. So our goal is to decrease that fever, decrease that inflammation, and hopefully not cause any long-term effects to the heart or those vessels. Most children will recover completely. Cardiac involvement is the most serious complication, which can lead to arrhythmias, CHF, and myocardial infarction. Let's stop here, and we'll start again.